We will be knowing about preeclampsia screening today. Coming to the statistics of preeclampsia, over 10 million women develop preeclampsia annually. Within 1 year, around 10 million, almost 1 CR of women develop preeclampsia around the world. Such dangerous disease with such huge numbers is a great burden on the society and on the healthcare of the world. 76,000 pregnant women die each year from preeclampsia and other hypertension disorders globally. And also, every 7 minutes, a woman dies out of preeclampsia or the complications of preeclampsia. And coming to the preterm births, every year, preterm births, 2.5 million occur because of the preeclampsia as a cause. And also the 5 lakh babies die each year due to preeclampsia out of the complications of the preeclampsia, and also the hypertension disorders annually, the one yearly. The only real treatment for preeclampsia and eclampsia, as we know, is to terminate the pregnancy, to prevent maternal morbidity and mortality, and prevent fetal death and damage. So there is no proper treatment. Only treatment is to terminate the pregnancy in whichever gestational age the pregnancy is. If we have to save the mother, we should not be looking for the fetus. And if we have to see for the fetus gestational age, we might not be saving the mother. So, because there is only one treatment for it, we have to align ourselves to screen it more so that we can prevent the development of the preeclampsia, also to delay the development of the preeclampsia, so that at a greater gestational age we will be getting a live fetus and not a preterm fetus, or at least the premature but near-term fetuses. And we have to remember that preeclampsia screening we have to start as soon as a pregnancy begins. As soon earliest we have to start at NT scan or first trimester scan or the NT scan. And also the number needed to screen to diagnose one pregnancy at risk for preeclampsia is comparatively less than other diseases. In numbers, it is 143. To diagnose or to detect one pregnant woman who could develop preeclampsia as the pregnancy advances is 143 for all the preeclampsias, and it is 250 for preeclampsias less than 37 weeks, that is preterm, and it is 400 for pregnancies less than 34 weeks, that is early onset preeclampsia. We have to know that early onset preeclampsia is that which occurs before 34 weeks, and late onset is after 34 weeks, and preterm is less than 37 weeks, and term preeclampsia is more than 37 weeks of gestational age. And what does this number needed to screen, when it is low, what does it imply? That our screening method is effective and also it is affordable and cost effective, so that we can screen less number of pregnant women to achieve the number of women going into preeclampsia. And if we see this slide, we can see that the Down syndrome is so less prevalent when compared to the preeclampsia. We have developed so many screening strategies and we are giving so much of economy out of the healthcare burden to diagnose the Down syndrome, but the preeclampsia having so much of prevalence, we have neglected it over the years. So how to detect it is the main crux of the subject today. And also with the preeclampsia, see the fetal growth restriction and also the preterm birth, so prevalent, and so prevalent are the FGR babies, and so prevalent are the preterm born babies arising out of the preeclampsia as the cause. Coming to this slide, in this we are going to learn How the 11 to 14 week screening for preeclampsia is also helping us to delineate the other obstetric syndromes and to develop a risk for other causes of obstetric syndromes. First, in 11 to 14 week screening, if there is an increased risk for preeclampsia, we have to determine the primary profiles that is contributing to the increased risk. We will be able to develop a personal risk for each pregnant woman, starting with the nulliparous state itself. And if we detect that the pregnant woman is at a higher risk out of the personal risk for the preeclampsia, then we have to start the low dose aspirin. Low dose aspirin, ecospirin, and low dose aspirin is the crux of this topic because it's the only strategy which we have to prevent the preeclampsia. And we can also give the placental risk categorization through that. And placental risk is based upon uterine artery PI, her clinical features, and also based on biochemical markers. So if we realize that the pregnant woman is at increased risk, then we have to initiate risk profile specific therapy by 16 weeks gestation age. Before 16 weeks gestation age, this is very, very important. Before 16 weeks, we will know further why the 16 weeks is a cutoff. Before 16 weeks only, we have to implement the low dose aspirin to her. And next is a cardiovascular risk. How do we know we have to look for the cardiovascular risk? If she has a history of hypertension, history of hyperlipidemia, history of congenital heart diseases, or any other heart diseases, then we have to start low dose aspirin. Along with that, we have to see that early blood pressure management is also initiated for such women. And if the pregnant woman is at increased risk for metabolic high risk category, then along with low dose aspirin, we have to advise weight control. Also, we have to start pravastatin and metformin. In the metabolic risk, which woman will be at a higher risk? History of PCOS, also pre-diabetes, history of insulin resistance, history of diabetes type 2 or type 1. They will be at an increased risk for this category. And coming to the prothrombotic risk, who will be at a higher risk with the R+, as well as any history of immune disorders. We have to start on low dose aspirin. Along with that, we have to initiate disease-specific anticoagulation like low molecular weight heparin, as we initiate in certain pregnant women in high-risk population, and also for high homocystinuria, high homocysteine. In cases of homocystinuria, we have to initiate the folate supplementation. So, coming to the effect of trophoblastic invasion into spiral arteries. Coming to the pathophysiology of the preeclampsia, we know that in the pregnancy, before pre-pregnancy state, the blood volume output is 50 ml per minute in the uterus. The blood flow is 50 ml per minute in the pre-pregnancy state, and it increases to 700 ml per minute during the pregnancy state. To accommodate such high blood flow, the vessels inside the uterus have to undergo certain changes. That is the trophoblastic invasion into the spiral arteries. The spiral arteries, the end arteries of the uterus, uterine arteries, the uterine blood vessels will be invaded by the trophoblast, the cytotrophoblast, the cells of the placenta. The extravillar cytotrophoblast of the placenta will be invading into the endothelium, and endothelium of the blood vessels will be replaced by trophoblast. will be replaced by vascular sinusoidal tissue. The extravillous cytotrophoblasts will be eating up the spiral blood vessels, the spiral arteries, a process called as pseudo-vasculogenesis. By this, the blood vessels will be turning into wide and low resistance and high capacitance blood vessels, by which the blood flow will be, the state of the pregnancy state, increased blood supply will be accommodated. And if this is not met, then we will be seeing the development of preeclampsia. And this certainly takes place in 2 waves, and it is completed by about 24 weeks. The first wave starts at 8 to 10 weeks, and the second wave starts at 16 weeks to 18 weeks, and it is completed by about 24 weeks. In this, the endothelium of the spiral arteries is replaced by the trophoblastic tissue, the vascular sinusoidal tissue. The blood vessels become much wider and less tortuous, allow more blood that is required in the pregnancy. Before 16 weeks, before the first wave, if we diagnose at least after the first wave is over and before the initiation of the second wave, that is before 16 weeks, if we diagnose and intervene, then we can prevent the bad second wave and we overcome the effect of defective trophoblastic invasion. So the defective trophoblastic invasion, we have to prevent it, so that we have to intervene before 16 weeks. That is the reason why 16 weeks of gestation is so important for our intervention to be implemented. The pseudo-vasculogenesis is the important term we have to remember at this point. Pseudo-vasculogenesis, where the extravillous cytotrophoblast transforms from an epithelial into a vascular sinusoidal tissue, downregulating the expression of adhesion receptors that are characteristic of their epithelial origin. It upregulates the expression of adhesion receptors by the vascular cells. So the epithelial cells are getting converted into endothelial cells. So the uterine influx increases during pregnancy from 50 ml per minute to 700 ml per minute during pregnancy. In pre-pregnancies, it is 50 ml per minute, and during pregnancy, it increases to 700 ml per minute at the end of pregnancy. This adaptation process happens because of the remodeling of terminal vessels of uterine arteries, called as spiral arteries, that are transformed into big vessels with low resistance. So the remodeling of terminal vessels of uterine arteries, that is the spiral arteries, get transformed into big vessels with low resistance. This happens due to substitution of the endothelium and vascular muscular layer. The muscular layer which is present within the vessels, it is the endothelium and the muscular layer which is present within the vessels are substituted to extravillous cytotrophoblast through the decidia and the part of the myometrium. They are substituted by the extravillous cytotrophoblast, the cells of the placenta. It is believed that the extravillous cytotrophoblast, with a process referred to as pseudo-vasculogenesis, transforms from an epithelial into a vascular sinusoidal tissue, downregulating the expression of the adhesion receptors that are characteristic of their epithelial origin. It upregulates the expression of adhesion receptors by the vascular cells. So, downregulation of adhesion receptors, that are characteristic of epithelial origin replaced by upregulation of adhesion receptors of vascular cells. These vessels undergo transformation from small muscular arterioles to large capacitance vessels. In preeclampsia, this transformation is reduced or absent, and uterine vessels maintain the same features that are present before pregnancy. So, the pseudovasculogenesis does not happen to a proper extent or happens in an abnormal form, and preeclampsia develops. This is the pathophysiology of the preeclampsia. Next, coming to the abnormal placentation that happens in the preeclampsia. There is abnormal trophoblastic invasion, because of which ischemia, there is decreased blood supply within the placenta. This activates the endothelial cells, and also there is vasoconstriction and microthrombosis. The vasoconstriction is not because of atherosclerotic type, but it is because of local vasospasm that induces vasoconstriction in the vessels. And also there is formation of microthrombosis that is the causative factor for all these situations of abruption, preeclampsia, HELP syndrome and stillbirth. We have to remember that preeclampsia is a 3-stage disease. In the stage 1, there is deficient proangiogenic factors. Proangiogenic, that is, which increase the angiogenesis. So, there is deficient proangiogenesis, that is, angiogenesis is at fault. The proangiogenic factors that are VEGF and PLGF. PLGF is very important with respect to preeclampsia as a disorder concern. It is a placental growth factor. It is a proangiogenic factor. In preeclampsia, the PLGF levels are decreased. So, the deficient proangiogenic factor expression, this is a stage 1. It happens in the decidua. In the stage 2, that is in the placenta, there is abnormal remodeling of the spiral arteries and trophoblast invasion. So, there is defective trophoblastic invasion. There is defective trophoblastic invasion that happens, and there is hypoxia reoxygenation. There is placental ischemia and hypoxia. There is decreased oxygen supply to the blood vessels itself, and this causes the initiation of oxidative damage, and because of that there is increased apoptosis, increased cell dying, increased cytokines. That is, there is a situation of pro-inflammatory. Cytokines will be increased in inflammatory state. So, there is a pro-inflammatory kind of situation that develops. Also, very important is that the SFLT1 levels are increased. We'll know what is SFLT is all about. We'll understand what more things about SFLT in the further slides. So, there is increased SFLT and there is endothelial dysfunction. This causes the increased peripheral vascular resistance leading to preeclampsia. And the current concepts in preeclampsia are placental dysfunction. Placental dysfunction causes placental ischemia and oxidative stress. This decreases the uterine artery flow. Decreased uterine artery flow, we will be understanding or detecting it through uterine artery Doppler waveforms and calculating the PI of the uterine artery Dopplers. And PAP-A is decreased. PAP-A is pregnancy associated plasma protein A, and PLGF is placental growth factor. Placental growth factor. This is PAP-A, and these are increased. These levels are increased, and in the vascular compromise because there is vascular compromise, because of the ischemia, there is endothelial activation, and we have seen in the previous slide that the apoptosis occurs and increased SFLT, and there is decreased PIGF and VEGF, the growth factors that aid in the angiogenesis. These are the growth factors that aid in angiogenesis. So, this is preeclampsia is an anti-angiogenic state. Therefore, these levels are decreased, and ultimately the end organ damage happens, which causes hypertension, proteinuria, liver dysfunction, coagulopathy and cerebral edema. Proteinuria due to kidney damage and liver dysfunction, we will be seeing that the liver enzymes will be elevated, and coagulopathy, thrombocytopenia and also DIC, all these develop as a consequence or as a complication of preeclampsia. Coming to the guidelines. Before we used to have ACOG guidelines and NICE guidelines, which only tells us that we have to see for the risk factors within the pregnant woman that describe the maternal risk association, and they have divided the risk factors into high risk factors and moderate risk factors. And the detection rate, if we use these risk factors only, ranges from 1 to 40%. It is always less than 40% and not more than 40%. The high risk factors are previous history of preeclampsia, so we cannot use them in the nulliparous. CRD, chronic renal disease, chronic hypertension, all the vasculopathies, diabetes mellitus, this is also a metabolic syndrome, SLE or APS, the antiphospholipid syndrome. If these risk factors are present, the woman is categorized into high risk group. And the moderate risk factors are first pregnancy. The nulliparity itself is a risk factor. Age more than or equal to 35 years, elderly gravidas, BMI more than or equal to 30 kg per meter square, interpregnancy interval of more than 10 years, family history of preeclampsia, and also black or poor. If you are belonging to the black ethnicity, the racial origin of Afro-American women, and also poor, implying the social status of the woman. These are according to the ACOG guidelines, and with little here and there changes are the NICE guidelines. Almost a similar risk factors are included. So the detection rate is very less when we consider only these risk factors. And also the high risk factors and moderate or other risk factors which we are utilizing or which we are keeping in mind in the present scenario are the prior history of preeclampsia, chronic hypertension, type 1 or type 2 diabetes mellitus, renal disease, autoimmune disease, antiphospholipid syndrome, SLE, young maternal age less than 25 years is also a risk factor. This is also a very important risk factor. Nulliparity is a very important risk factor which we tend to forget. Advanced maternal age, family history of preeclampsia, long interpregnancy interval, BMI more than 30 or 35. 30 according to the ACOG and 35 according to the NICE guidelines. Multifetal gestation, family history of early onset cardiovascular disease, history of SGA or adverse gestational outcomes, previous miscarriage with the same partner, low maternal birth weight of preterm delivery, increased pre-pregnancy triglyceride levels. So if there is increased triglycerides before the pregnancy, that also has to be kept in mind as a risk factor. Heritable thrombophilias, connective tissue disorders, vaginal bleeding in early pregnancy, gestational trophoblastic disease and drug abuse. We have to look at these risk factors too. So we have seen that when the high risk factors are used, the detection rate is only 40%, and we cannot give personalized risk to each woman using these guidelines or the high risk factors. If we use the FMF guidelines, which we are going to see that this the Fetal Medicine Foundation guidelines, which are developed recently, utilizing the FMF parameters, the detection rate can reach up to 100%. Maternal characteristics, so it is a multimodal screening approach. It is a multimodal screening approach, the FMF guideline says about that, which includes maternal characteristics, 2. Uterine artery Doppler, 3. Mean arterial pressure, 4. The biochemistry PAP-A and PLGF. PAP-A and PLGF. Combined, if we utilize all these various parameters, then the detection rate will go up to 100% in preterm and 80% in term preeclampsias. So we have seen that it is a multimodal screening approach. With preeclampsia in first trimester, according to FMF, extended clinical history along with PLGF plus PAP-A plus UTPI, uterine artery PI, mean arterial pressure, the PE risk under 32 weeks, detection rate is 100% and under 37 weeks, detection rate is 80%. So now we'll know few important points about uterine artery Doppler, how we will measure the uterine artery Doppler, how it is calculated, how we use it in the screening for preeclampsia. Uterine artery Doppler, we can conduct it as early as in first trimester. We have to take a uterus and cervix mid-sagittal section. We have to focus on the cervix and we have to tilt. We have to acquire a mid-sagittal focused view of the cervix and we have to tilt our probe sideways so that one side, the right uterine artery, on the other side, left uterine artery, the sideways tilt uterine arteries are identified. We have to place our pulsed wave Doppler on the uterine arteries and the sample gate should be always only 2 mm to include the whole of the uterine artery. And it is positioned on the ascending branch of the uterine artery at the point closest to the internal os. So if this is the uterus and this is the cervix, we have to place, if we identified the uterine arteries on either side of the internal os, we have to place our sampling gate very nearer to the internal os because at that point is actually we are assessing the ascending branch of the uterine artery with an inclination angle of less than 30 degrees. What is the inclination angle and why it is always should be less than 30 degrees? We will be knowing in our Doppler module. Then the PSV, if we get, we have to sample that uterine artery and then we will be acquiring a waveform that is specific to the uterine artery. And if we are doubting that whether we have correctly taken the uterine artery sample or not, we have to see at the peak systolic velocity. If it is more than 60 centimeters per second, then only we should confirm that it is corresponding to the uterine artery. And then PI is measured when at least 3 consecutive similar waveforms are obtained. And we have to take right uterine and left uterine, mean of it, mean uterine artery PI. We have to convert it either into moms or we have to convert it into centiles, and more than 90th centile, we have to make the pregnant woman aware that she is at a high risk for preeclampsias. Detection rate alone with the uterine artery Doppler is 40 to 50%. Uterine artery PI plus maternal medical history, we have, so only maternal is 40, only uterine is also 40. Combining both, we can improve it up to 70 to 80%. It is all the number game with the preeclampsia, with the screening of the preeclampsia module. So uterine artery PI more than 90% for the gestational age is documented as resistant. Some guidelines say that we have to take it more than 95th centile and some say that we have to take more than 90th centile. Taking the 90th centile is better because we will be involving more women which are at high risk. We can label more women as high risk and we can intervene more so that at least one pregnant woman, at least the number of pregnant women that are diagnosed, that are detected as high risk, and the intervening percentage will be increased. Uterine PI is higher at os than the iliac crossover. We need to know that in transabdominal scan, we will be taking the Doppler of uterine arteries in the iliac fossa where the uterine arteries will be crossing the external iliac vessels. There we have to take the uterine artery Doppler, that is in the transabdominal. In transvaginal scan, we will be taking at the internal os because this is at the iliac crossover is higher at os than the iliac crossover. Uterine artery PI is higher at os than iliac crossover. That's why TVS is more than TS. So the TVS PI are always more than the TS PI because we are measuring in the TVS at the internal os level and in the TS we are measuring at the iliac crossover. The distance of resistance, therefore there is the distance, there is a gap in the PI, and always a TVS PI are more than the TAS, and we have to use the appropriate nomograms. We should not use the TVS PIs for the TAS and TAS for the TVS. Why we are utilizing only the PI? We know that the Doppler, we can calculate PI, RI, S by D. But in recent times, we are not utilizing S by D and RI, that is the resistance index and the systolic to diastolic ratio. But we are only utilizing the PIs because it is an averaged value of all maximum velocities during the cardiac cycle. So it is a representative of whole cardiac cycle. And it is more stable and it does not approach infinity when there are absent or reverse diastolic values. So PI does not approach the infinity as with other values. These values will approach infinity, but PI will not approach the infinity. That is a good point to utilize the PI. And uterine artery notching has been implied of no significance and only the PI is given importance. Previously, we used to consider that if there is notching within the uterine artery waveform, then that is significant as high risk. But now the notching has not been given any importance and it is only the PI that is given importance. See, coming to this slide, we will be seeing here the iliac vessels. This is the iliac artery and the iliac vein. This is the uterine artery crossing over from the external iliac vessels. The uteroplacental circulation, we will understand a bit with the help of this slide. The spiral arteries undergo the trophoblastic invasion and dilated tortuous vessels with no musculoelastic tissue. We have to remove the musculoelastic tissue has to be replaced completely so that the vessels will be dilated and more blood flows through that. First wave includes the decidual arteries and the second wave includes the myometrial arteries. We have already seen that the second wave will be at 16 weeks and completed by 24 weeks. That's why we are intervening. We have to intervene before 16 weeks. So in the first slide, we have seen that second wave at 16 to 18 weeks, initiates at 16 weeks and 18 weeks, and first wave between 8 to 10 weeks. That is the reason why we have to intervene before 16 weeks. And here they are telling that the decidual arteries will be involved in the first wave and the myometrial arteries, the trophoblastic invasion occurs in the myometrial arteries in the second wave. The end result is that the low impedance circulation which facilitates more feto-maternal exchange. Here in the first trimester, we have to always remember that when the diastolic flow is less, that implies increased resistance. In this first waveform, from the baseline, the diastolic flow is very less. In the second, comparatively more, but this is in the second trimester. And in the third trimester, it is more from the baseline. If this diastolic flow is more nearer to the baseline, then that implies that it is increased resistance. This is the impedance to flow in first trimester high, and in impedance to flow in early second trimester is also high, and impedance to flow in late second and third trimester is low. It has to become low as the gestation age advances, and if it doesn't happen that way, then the preeclampsia risk is more. This is a waveform representing the uterine artery, and this is how we are taking. This is a sample gate where it is completely within the vessel and it has to be 2 mm for us to activate, for us to take the or obtain the uterine artery Doppler. High impedance in uterine artery flows leads to high risk of preeclampsia. Not only the preeclampsia, also the fetal growth restriction, because there is no proper blood supply, because there is no proper feto-maternal exchange, because there is increased placental resistance, increased resistance at the level of placenta. That's why there is decreased blood flow to the fetus, and fetus won't be able to get proper nutrients and it will go into the FGR, fetal growth restriction. And because of FGR and because of sudden preeclampsia and complications developing, there will be more higher chance of emergency C-section deliveries. And there is also high risk, high chances of placental abruption occurring. Also shorter duration of pregnancy. We have seen that the preeclampsia decreases the gestational age of which the pregnant woman can carry her fetus to term. So there is shorter duration of pregnancy because of preeclampsia affecting the woman. She cannot carry the fetus up to term. Majority are preterm, majority are early onset preeclampsias. And also because of all that, there is preterm birth, there is also chances of stillbirths, chances of IUDs, chances of more NICU admissions, all gets increased, and there is absolutely poor neonatal outcome in preeclampsia. And coming to the second factor that we are including in the multimodal screening approach is a mean arterial pressure. FMF suggests we have to use only electronic sphygmomanometers, electronic machines for the usage, for the detection, for measuring the blood pressure in the pregnant woman. The woman should be in a comfortable seated position with her arms supported at the level of the heart and legs uncrossed. The legs should be always uncrossed because legs crossed will increase the resistance in the peripheral blood vessels. And arm should be supported at the level of the heart. Cuff size should be selected depending on the mid-arm circumference. Cuff size should be selected depending on the mid-arm circumference. Neither observer nor patient should talk for 5 minutes before or during the measurement. And BP should be measured in both arms simultaneously. This is a very, very important point. It is not like one arm initially and then the second arm. It is not like that. We have to measure BP in both the arms simultaneously of the pregnant woman. Not unilateral, not one after the other, but bilateral simultaneously. Bilateral simultaneously is a very important point. Series of recordings at 1 minute intervals. We have to take a series of recordings and we have to utilize minimum of 2 recordings to give an approximate measurement, and it is recommended to take the measurements until variations between consecutive recordings fall within 10 mmHg of systolic and 6 mmHg in DBP in both arms. So the difference should be 10 mm in SBP and 6 mm in DBP, and then the last 2 measurements are used. Either we can utilize in this manner or minimum of 2 recordings should be utilized and average of it should be taken. And we have to remember that it is neither SBP by DBP that we are utilizing to give the risk categorization, and it is the mean arterial pressure. We are not utilizing this. We are utilizing the mean arterial blood pressure. Mean arterial pressure, that is given by the definition of diastolic blood pressure with 1/3 of this difference of SBP minus DBP, and the machines have automatic recordings availability nowadays, so there is no need that we give the mean arterial pressure on our own, and we can feed the values to the machine and we can get an automated measurements at the end. And after the uterine artery Doppler and the mean arterial pressure, we will know what are the aneuploidy analytes telling about the preeclampsia screening. First one is PAP-A, Pregnancy Associated Plasma Protein A. PAP-A stands for Pregnancy Associated Plasma Protein A. This activates growth factors required for fetal growth. So what is its function? PAP-A activates the growth factors required for fetal growth, and abnormal values, it is always, all the aneuploid analytes always are measured in moms. The values are given in moms, that is multiples of median. Mom is multiples of median. If the PAP-A is less than 0.35 mom or equal to or less than 0.35 mom, then it is abnormal. If it is abnormal, what does it say is that the woman is at higher risk of developing preeclampsia. PAP-A is a component of double marker as well as and quadruple marker. Double marker as and quadruple marker. PAP-A is released by the early developing placenta. Thus, the amount of PAP-A in the maternal blood reflects the size of the footprint of the placenta on the uterine wall. Alpha-fetoprotein is a component of the quadruple marker. That is why we are telling them as aneuploidies analytes. Alpha-fetoprotein, it is made by the developing baby's liver, 2 mom or greater. AFP is a large protein that is made by the baby's liver. It leaks into maternal blood across any skin defect like a spina bifida lesion on the baby's back. With a structurally normal fetus, elevated maternal AFP levels may be due to a leaky, damaged placenta. So, 2 mom or greater, increased risk. Total HCG, it is made by the outer skin of the placenta, that is a syncytial trophoblast. This layer also makes anti-angiogenic protein SFLT1. So, SFLT1 is derived from the syncytial trophoblast that is largely responsible for causing the hypertensive disease preeclampsia. And this is the inhibin. This protein is also made by the outer layer of the placental villi, same as the HCG as well as the SFLT1. If it is 3 mom or greater, it is abnormal, and in HCG, if it is 4 mom or greater, it is abnormal. Inhibin is also made by the outer syncytial trophoblast. Dual elevation of both HCG and inhibin poses a very high risk of severe preeclampsia. So, these are the aneuploidy markers or the aneuploidy analytes that indicates which women are at high risk or which women are at low risk for the development of the preeclampsia. So, PAP-A, we have seen pregnancy associated plasma protein A, 0.35 mom or less. It reflects the size of the footprint of the placenta on the uterine wall. And coming to this slide, if we are including maternal history along with PLGF, early preeclampsia detection rate has increased to 72%, and all preeclampsias less than 42 weeks also has increased up to 40%. And if we see in this chart, by combining PLGF, PAP-A, uterine artery Doppler and mean arterial pressure, PLGF, PAP-A, uterine artery Doppler and mean arterial pressure, we are increasing the detection rate up to 93%, 96%, and the values are far more better than we utilize only the maternal history. Here also, if we see into this table, mean arterial pressure, uterine artery PI, PAP-A, PLGF up to 100, up to 80, up to 43. Mean arterial pressure, UTPA, not a single only one doesn't increase. It is a combined effect of all the screening methods that increases the detection rate. And coming to the aspirin, the ecospirin, the only intervening model or the only intervening precaution which we can take in cases of preeclampsia high risk women. The dose is 150 mg per day, preferably at night time or bedtime. The dosage is important because previously we used to use 75 mg, 81 mg, but it is clearly the FMF guidelines are saying that we have to utilize only 150, we have to prescribe only 150 mg per day to the pregnant woman, and preferably the pregnant woman has to take at night time or the bedtime, and we have to start at 12 weeks so that we are delaying the second wave, we are interrupting the second wave, and we are interrupting the defective trophoblastic invasion into the spiral arteries. We have to start at 12 weeks and finish at 36 weeks. Why at 81 mg we are not utilizing and 150 mg we are utilizing? Because of the something called as aspirin resistance. Aspirin resistance is more at lower doses and it is low at higher doses. That is why we have to give higher doses. And aspirin at night, some studies have given that there is lower incidence of preeclampsia, fetal growth restriction, preterm birth or IUD with all these. And we have to stop at 36 weeks. Why we have to stop at 36 weeks and why not up to delivery? We have to continue that to avoid the hemorrhage in the neonates, the neonatal intraventricular hemorrhage and hemorrhage in other organs of the fetus, of the neonate. Again, the 150 mg is the dose, as the resistance to dosage at lower levels is more. So we have seen that it is a multimodal screening approach, maternal characteristics, mean arterial pressure, uterine artery Doppler, PAP-A and PLGF. And with this, we can achieve a detection rate of 100% in less than 32 weeks of gestation, preeclampsia high risk categorization, and in less than 37 weeks, it reaches up to 80%. And according to Lancet, 2.4 mg per kg body weight should be the aspirin. And at night after 16 weeks, should we give or not? We have seen that less than 16 weeks we have to give, and if we detect or if the mother presents to the OPD late and if we give the risk categorization at a later gestational age, can we start the aspirin even after 16 weeks? Yes, because it may not have the complete effect, but it will prevent preeclampsia, and also it reduces maternal and fetal morbidity by 10%. So start later if the preeclampsia labeling has been done later or has been confirmed later. Aspirin delays the development of preeclampsia. There is no harm if started later too when the patient presents after 16 weeks for the first time. It reduces the maternal and fetal morbidity by 10%. So start little later if the preeclampsia label is confirmed later. Coming to the biomarkers of preeclampsia according to the gestational age wise. At 12 weeks, we have to use mean arterial pressure, uterine artery PI, PLGF. At 22 weeks, we have to add on SFLT1 along with these. And at 32 weeks also, we have to add on SFLT1. And at 36 weeks, we are reducing it to only mean arterial pressure, PLGF and SFLT1. The maternal serum biomarkers. We have seen that placental growth factor comes from the cytotrophoblast. It belongs to VEGF family, that is vascular endothelial growth factor family, promotes non-branching angiogenesis, and it promotes low resistance in the vessels. So lesser the PLGF, more risk. And PAP-A comes from syncytial trophoblast. It increases the levels of insulin-like growth factor. The placental growth factor detection rate is 90 to 95% for early onset preeclampsia before 34 weeks. When used in combination with the maternal factors and other biomarkers, assessment of the placental insufficiency is linked to fetal growth restriction. Interpretation of the results. We have to always see if the placental growth factor levels are low. If it is less than 5th centile, it indicates the impaired placental function. Less than 5th centile, impaired placental function. Coming to the PLGF, it is an angiogenic protein synthesized by the syncytial trophoblast. A low PLGF concentration is a reflection of placental dysfunction and correlates strongly with time to delivery in women with suspected preterm preeclampsia. Other tests used for the prediction of time to, so PLGF and SFLT1 we can utilize to predict how much of time is there before we deliver the fetus, and the SFLT1 to PLGF ratio we can utilize as a biomarker for timing the delivery in preeclampsia women. The placental proteins in preeclampsia, the current research says that PLGF and SFLT1 levels in late first or second trimester appear to predict early onset preeclampsia with a high sensitivity and specificity. To predict the early onset preeclampsia, SFLT1 and PLGF are very good, that are used in late first or second trimester with high sensitivity and specificity. They are able to give us. And also VEGF family proteins do not have sufficient statistical power to accurately predict late onset preeclampsia, but may be useful in detection of early onset. So VEGF family also for early onset preeclampsia, SFLT1 and PLGF for early onset preeclampsia, and placental protein 13, PP13 levels that are low in the first trimester of pregnancy confer a higher risk of developing preeclampsia later in pregnancy, but we are not utilizing these in the current practice still. There is a lot of research that has to go on still before we get them into the clinical practice. Coming to the second trimester screening for preeclampsia. For the patients presenting late or as a continuation of the patients that who presented in the first trimester, we will categorize them low risk and high risk, and again in second trimester, we will again categorize them. The surveillance plan for the second trimester and third trimester, we can utilize a free FMF software that is available to calculate the risk of preeclampsia at anomaly scan. For screening of the patients in the anomaly scan, we will be utilizing the FMF software. It is the FMF software combinedly uses the maternal characters, the medical history, the obstetric history, pregnancy characteristics, biophysical measurements, biochemical measurements. So this is the FMF software website where we are able to give the second trimester risk categorization, that is at the anomaly scan. The risk can be derived from the maternal history and any combinations of the biomarkers, that is the PLGF and SFLT. Biochemical measurements include serum PLGF. We can convert into mom, or we can directly utilize the raw data. If we are not utilizing them, we can click on the no button. These are the biomarkers. The values for the PLGF and SFLT depend on maternal characteristics and reagents used for analysis, and they therefore need to be converted into moms. In the application below, you can either use the mom values reported by the laboratory or provide the raw data, and the mom values will be calculated automatically. So the pregnancy type, singleton or twins, we have to tick. Pregnancy dating, gestational age, how many weeks and days, and the examination date we have to include. In the maternal characters, the date of birth for the age, height and weight for calculating the BMI, racial origin, we have seen it already. Smoking during pregnancy, we have to see whether there is smoking during pregnancy, yes or no. Mother of the patient had preeclampsia. This also we have to take into consideration whether the mother of the pregnant woman has developed the preeclampsia. The conception method, is it natural or artificial reproductive technology has been utilized, and the medical history we have to see whether the mother is a chronic hypertensive, diabetes type 1, diabetes type 2, SLE, antiphospholipid syndrome. In the obstetric history, we have to see whether she had any earlier pregnancies, or whether she is a nulliparous woman, no previous pregnancies at more than or equal to 24 weeks, parous, at least one pregnancy at more than or equal to 24 weeks of gestation. And in the biophysical measurements, we have to include the mean arterial pressure, mean uterine artery PI, and also the date of measurement. So the screening for the preeclampsia at 19 to 25 weeks. Screening at this stage should ideally be a combination of all these and serum PLGF, and risk for preeclampsia less than 32 weeks, less than 36 weeks should be calculated. On the basis of these risks, the women are stratified into high, intermediate and low risk management groups. High risk group would require close monitoring of high blood pressure and proteinuria between 24 to 31 weeks. The intermediate risk group, together with the undelivered pregnancies from the high risk. So some of the deliveries will go on to deliver in some of the high risk pregnancies will be delivering in this window, and from those undelivered pregnancies, they will be put into the intermediate risk group, and again we will have a risk assessment at 32 weeks, and again we have to do close monitoring for high blood pressure and proteinuria between 32 to 35 weeks. At risk cutoff of 1 in 25 for preeclampsia less than 32 weeks we have to utilize, and at risk cutoff of 1 in 150 for preeclampsias less than 36 weeks we have to utilize. All pregnancies would have reassessment of risk for preeclampsia at 35 to 37 weeks to define the high risk group for term preeclampsias. So if we see this slide, we will be knowing that first trimester screening between 11 to 13 weeks. All pregnant women have to be screened. This has to be universal screening. Maternal risk factors, MAP, uterine PI, PLGF, PAP-A. If PAP-A is available from aneuploidy screening, then we have to utilize it. In absence of PLGF, we have to label them as either high risk. If they are labeled as high risk, aspirin has to be started. If they are labeled as low risk, no aspirin. And again in second trimester, risk assessment we have to do in all asymptomatic women. All patients receive scan and uterine artery Doppler either as part of FMF combined algorithm at 19 to 24 or independently at 18 to 22 weeks. It is falling with the gestational age when we do the anomaly scan. High risk patients remain as high risk following second trimester assessment, which guides frequency of monitoring. And low risk patients with high risk by FMF second trimester combined algorithm or abnormal uterine artery, that is PI more than 95th centile or PI more than 90th centile, are reclassified as high risk. In the low risk, standard surveillance and reassessment at only 35 to 37 weeks. In intermediate risk, reassessment of risk at 30 to 34 weeks. And in high risk, we have to do home BP monitoring, and also we have to see for proteinuria and weekly clinical assessment of BP at 24 to 31 weeks. And we have to include SFLT1 and PLGF if these are included, if these are measured between 24 to 28 weeks. Based upon the SFLT1 to PLGF ratio, the values, we will be categorizing the surveillance. If it is less than or equal to 38, standard surveillance is enough. If the SFLT to PLGF ratio is more than 38 and less than 85, increased surveillance is required. And if it is more than or equal to 85, then high level of surveillance like this. Again, the pregnant woman has to follow this category. And if the low risk is, if the pregnant woman falls under low risk based on both first and second trimester screening, risk assessment at 36 weeks by either 35 to 37 week FMF combined algorithm or only SFLT and PLGF. The clinical suspicion of preeclampsia after 24 weeks. This will be done by again the SFLT to PLGF ratio, wherein if it is less than or equal to 38, progression within 1 week is unlikely. And if the SFLT to PLGF ratio is more than 38, progression within 4 weeks is likely. And according to our FIGO, there is something called as gestosis score that has been developed for the Indian population, where we will be scoring each risk factor, and if it is more than or equal to 3, we have to increase the high risk surveillance and we have to initiate the aspirin in such women. For one, we have women born as small for gestational age older than 40 years, age younger than 20 years, obesity, nulligravida, family history of preeclampsia, family history of cardiovascular disease, PCOS, interpregnancy interval more than 5 years also has 1 score, and maternal hypothyroidism is also included in this. And for 2 score, we include gestational diabetes mellitus, obesity, multiple pregnancy, up to 2, and for 3, hypertensive disease during previous pregnancy, pre-gestational diabetes mellitus, chronic hypertension, inherited thrombophilia, acquired thrombophilia, A+ or SLE, maternal chronic kidney disease, and assisted reproductive. So all the pregnant women who get pregnant under the artificial reproductive technology will directly be high risk. And the last one, coming to the ophthalmic artery Doppler. Ophthalmic artery Doppler is a simple, accurate and objective technique with a high predictive value in the detection of all types of preeclampsia. It is a recently developed one. It can be included along with the other screening methods to increase the detection rate. Ophthalmic artery Doppler changes are due to maternal hemodynamic adaptation to pregnancy and not due to trophoblastic invasion. So it differs from the uterine artery Doppler in this sense that it is the changes in the Doppler of the ophthalmic artery are due to the maternal hemodynamic adaptation. In this, we will be calculating what is called as peak ratio. If this peak ratio, that is the peak systolic velocity of the second wave by the peak systolic velocity of the first wave, the ratio, if it is more than 0.9, then that woman is at an increased risk for the development of preeclampsia. Here we could see that in American Journal of Obstetrics and Gynecology, this article by Kypros Nicolaides telling that the ophthalmic artery Doppler, how the detection rates are in the prediction of preeclampsia. With a false positive rate of 10%, the delivery with preeclampsia within 3 weeks and at any time after assessment at 35 to 37 weeks. Gestation by maternal factors, ophthalmic artery second to first peak systolic, that is the peak systolic velocity of the second peak by peak systolic velocity of the first peak. We utilize that ratio and combinations of mean arterial pressure, uterine artery PI, serum PLGF and SFLT. We could increase from 31 to 69 and almost up to 93 with other methods. When ophthalmic artery Doppler is included with other screening methods, it has been improved. The detection rate has been improved up to 93rd percentage. 93%. And this slide is telling of the delivery with preeclampsia at less than 37 weeks and more than or equal to 37 weeks gestation in screening at 19 to 23 weeks gestation, that is at the anomaly scan. By maternal factors, ophthalmic artery second to first PSV ratio and combinations with other screening methods, we are able to increase it up to 80th percentage or 80%, and with all others included plus ophthalmic artery, we are able to increase it up to 90%. How do we calculate the ophthalmic artery Doppler? How do we record the ophthalmic artery Doppler? We have to make the patient lie in supine position with 5 minutes of rest with the linear probe, that is 7.5 megahertz linear probe we have to utilize for this, and we have to place the probe on the eyelids of the pregnant woman, and we have to identify the ophthalmic artery, that is the only single blood vessel that is present posterior to the globe, posterior to the orbit, that is superior and medial to the hypoechoic band. It is superior and medial to the optic nerve. We have to put on the color and identify the ophthalmic artery blood vessel. The angle of inclination should be less than 20 degrees. Sample gate should be 2 mm only again, and depth should be 3 to 4.5 centimeters. We will know about what is the sample gate, depth and high pass filter, PRF, all this in the overview of the ultrasound. The PRF should be 125 kilohertz. Increased high PRF we should be utilizing for this Doppler, and the high pass filter should be 50 Hz, and duration of examination, it takes only few seconds. We have to identify the ophthalmic artery, put on the sample gate, adjust the sample gate width and activate the pulse wave Doppler and take the waveform. Average of 4 measurements we have to take, 2 from each eye, and we have to utilize it to calculate the average PI and PSV ratio and PSV of second peak. So the first peak of systolic velocity, the PSV, second PSV1, PSV2, PI and the PSV ratio we have to calculate, and if the PD1, that is the peak systolic velocity of the second wave, also called as the first diastolic peak, if it is more than 24.56 centimeters per second, then we have to categorize that pregnant woman into high risk. And if the peak ratio, that is the PSV ratio, PD1 by PSV, we are calling it as PD1 because it is the first diastolic peak velocity. The PSV2 is equivalent to first diastolic peak. So PD1 by PSV ratio is significantly increased in preeclampsia cases. If it is more than 0.6, then the woman is at higher risk for preeclampsia development. This is the slide telling us about how we are obtaining the ophthalmic artery Doppler. This is the ophthalmic artery. behind the globe, the only blood vessel we could see, and it is medial to the optic nerve. And on this we are placing the pulsed wave Doppler, adjusting the sample gate, and then activate this button. We will obtain a waveform like this. This is the first peak, this is the second peak, and this is the diastolic. This is the end diastolic point. This is the diastolic waveform. This is the systolic peaks, and this is the diastolic peak. So again we are able to see that the PSV1, the first peak systolic velocity, we have to calculate at the height at the top of the first peak, and this is the second peak, the peak systolic velocity of the second peak. This is a normal one, and in this we are able to see that the PSV2 is comparatively more when compared to the first figure. This is almost touching the 40. This is around 24. So the PSV2 is increased when compared to the normal, and the PSV2 to PSV1 ratio is also increased in such patients. When we obtain such spectral wave Doppler of the ophthalmic artery, we have to categorize them into high risk. Thank you.